Yes, Kulani, please.
Good morning to all. Hello to everyone joining today's webinar. I am Dr. Pradeep Golani, and as the co-convener of this event, I am delighted to welcome a diverse and engaged audience. Your participation greatly enriches our discussions and underscores our shared commitment to advancing in our respective fields. I look forward to productive conversations and collective learning as we embark on this educational journey together. SPSR is distinguished for its engaging webinars, further enhancing its status as a leading platform for continuous professional development in the pharmaceutical sector. I am confident that today's session will uphold our tradition of excellence, providing valuable insights from our respected speaker. Let us seize this chance to gain new knowledge, participate actively, and progress in our field. Welcome, everyone. I look forward to a productive experience for all the participants. Thank you for joining us today. We are gathered today to commemorate the 90th SPSR webinar on integrative approaches in dementia, synergizing traditional medicine with modern science. A distinguished event hosted by the Society of Pharmaceutical Sciences and Research under the esteemed guidance of Dr. Shashi Alok, National President of SPSR. The Society continues to play a pivotal role in fostering innovation and advancement in the field of pharmaceutical sciences. The SPSR is devoted to advancing the pharmaceutical field through a variety of strategies. Our mission is to organize conferences that support pharmacy-related initiatives and endorse programs tackling public health issues in India, focusing particularly on disease prevention. We make it a priority to recognize and honor pharmacists whose notable contributions drive progress in our field. At the heart of our mission is a commitment to spreading pharmaceutical knowledge, ensuring a steady and robust exchange of information about pharmaceutical practices and services. By striving towards these objectives, we aim to elevate the quality and impact of the pharmacy profession, fostering a proactive and collaborative community dedicated to excellence. It is our privilege to introduce Dr. Rakesh Barik, Assistant Professor, GITAM School of Pharmacy, GITAM Deemed to be University, Hyderabad, Telangana, India, as a distinguished speaker. Dr. Rakesh Barik expertise greatly contributes to our event, providing substantial knowledge and insights. His participation is certain to enrich our discussions and expand exploration of integrated approaches in dementia. We are grateful for his engagement and anticipate an enlightening session. It is our privilege to introduce Mrs. Monika Sabharwal as the convener for today's webinar, who also serves as the founder and National Secretary of SPSR and CEO SPSR Periodicals Private Limited. Her significant involvement and leadership in the pharmaceutical sciences and research communities are indicative of her commitment to the field. We are very grateful to have her guidance in today's session. Now we will start with the short introduction to guest profile. Dr. Rakesh Barik is an academician and researcher in the field of pharmacognosy and herbal drug research, currently serving as the assistant professor at GITAM School of Pharmacy, Hyderabad, since 2017. With over 18 years of experience in teaching and research, he has previously held academic positions as professor and associate professor at reputed institutions, including Koringa College of Pharmacy and Smriti College of Pharmaceutical Education, Indore. Dr. Barik holds a PhD from Jawaharlal Nehru Technological University, Hyderabad, and an m.pharm in pharmacognosy from Manipal College of Pharmaceutical Sciences. He completed his b.pharm from Sri Jaidev College of Pharmaceutical Sciences, Utkal University. An accomplished researcher, Dr. Barik has authored over 40 publications in peer-reviewed journals, contributed to multiple book chapters, and has two patents, one Indian and German, to his credit. He has also authored two books in the domain of natural products and drug delivery. His areas of expertise include herbal pharmacology, nutraceuticals, nanoformulations, and in vivo in vitro pharmacological evaluation of natural products. He has guided over 30 undergraduates and 50 postgraduate research projects and is actively supervising PhD scholars. His research work has been presented at over 21 national and international conferences, and he has delivered 10 invited lectures across various academic platforms. Dr. Barik has also been associated with the government and industry funded projects, including consultancies for Marico, Kevin Care, and Arjuna Naturals. He was a co supervisor in a state funded anti diabetic and antioxidant study, showcasing his capability in translational research. He also holds significant academic leadership roles, including IQAC and academic coordinator, R&D head, and Animal House in charge, and has served as the coordinator for NBA, NAC accreditations, and AICT CII initiatives. Additionally, he is certified behavioral and mentoring analyst and a graduate for the IUCEE International Educators Program. Dr. Barik's contribution to teaching and research have earned him several accolades, including multiple Best Teacher Awards and the Shiksha Shri Award in 2018. As an active speaker in national forums, his work continues to inspire innovation in herbal drug science and education. It is with great satisfaction and pride that we declare that we have exceeded 1,300 registrations for this webinar. Registrations are received from India, Algeria, Egypt, Ethiopia, Kenya, Kazakhstan, Malaysia, Mexico, Nepal, Nigeria, Oman, Saudi Arabia, UAE, Uganda, Vietnam, and Uzbekistan. We are deeply moved by the substantial and varied responses we have garnered. Our heartfelt gratitude is extended to each person who has taken a moment to participate in this significant event. Thank you all for joining us today. Let's make this webinar an insightful and enriching experience for everyone involved. We have our esteemed keynote speaker, Dr. Rakesh Barik, with us. Welcome, sir. Your insights would be highly valuable, and I would appreciate if you could present them in a speech. Over to you, sir.
Thank you very much, Dr. Pradeep. So good morning, conveners and all the personnel of SPSR for giving me this opportunity, and all worldwide enthusiastic minds who have joined today for this presentation. So as announced, so I will be sharing. Yeah. Is it visible, Dr. Pradeep?
Right, sir. It's visible, sir.
Okay.
Perfect.
Yes. So integrative approaches in dementia, synergizing traditional medicine and modern science. So coincidentally, this is the 90th webinar. And again, coincidentally enough, what we are discussing today will not wait till we become 90. It happens when we are 60 and onwards, and for which we have to take care from a much earlier stage. So to start with, I will be covering under these contents, starting an introductory note of dementia, a bit about the history, when it was medically recognized, leading to the milestones achieved that led us to a modern understanding and giving important considerations, exact signs and symptoms, exact causes, coming to the types of dementia, how the brain looks like and what exactly happens during dementia, how do we know what diagnostic tests are supposed to be performed, risk factors that are already there that leads to dementia, finally to the pharmacological treatment, the medicines used, and why we have this integrative system, synergizing approaches. Then we have under phytotherapy, the medicinal plants that have been studied for dementia, how they are studied, what models they have been used. Then role of nano formulations for dementia, diet and dementia, what is the correlation? A concluding remark followed by the references, of course, to start with. So, dementia may not be new for many of us. It's not a single term, it's a collective term. Collective term for a range of mental, cognitive, or understanding disorders. And there is a gradual decline in memory, reasoning, language, coordination, mood, and in the general behavior. That is an overall meaning of dementia. A little bit of the history. The word dementia came from the Latin word demens in the 13th century, and it meant being out of one's mind. So it is nothing new, but Egyptians and Greeks, they have already found out that old age can be associated with certain memory problems. It was under observation. And Greek philosophers like Solon, they even wrote about it, impairment of judgment due to old age. So following this, there were many views. Philosophers like Pythagoras, Cicero, they also viewed old age that it is an age of mental decline. And then Cicero, a further step ahead, there should be some intellectual activity to combat this decline or salinity. Then, as studies increased and as research increased, 18th century, first of all, the medical community started recognizing dementia as a condition. So physicians, Pinel, Esquirol, they observed the brain diseases. 19th century, individuals with dementia were finally called as patients who needed actual medical care, and senile dementia came to be used. Further, 20th century, further traction was given to dementia. Types of dementia were recognized, making a shift towards proper understanding the exact brain pathology underlying dementia. Following these studies, some milestones. German psychiatrist Alois Alzheimer, whose name we are using till date for this disease, he published a case study of a woman, 50 years old, with dementia symptoms. So she showed memory loss, certain psychological changes, and then when the post-mortem study was done on her brain, he observed the microscopic plaques and tangles. We will see them later. What are these? So plaques, from a layman's point of view, as deposition. Tangles is twisting network. Then Alzheimer's sir, his guide, Emile Kerplin, he gave the name of his student Alzheimer as Alzheimer's disease in his book, Handbook of Psychiatry. So here he discussed about the early onset cases from the more common senile cases. So he gave the name of the disease after his student's name. So this led to the modern understanding that it is not a single, but dementia is a group of diseases which may cause cognitive decline. It may result from a variety of diseases, injuries, infections, and among all, Alzheimer's disease is the most prevalent form of dementia, which accounts for around 70% of the cases. So then came certain considerations upon studies. So we say that upon aging it happens, but it is not a natural part. There are many other factors. Age is one of them, but not the ultimate factor. There's a family history. There are certain lifestyle choices. We will see them. So there's no perfect cure for dementia, but there are certain treatments that can manage the symptoms and improve the quality of life. And the most important thing, memory loss doesn't always necessarily confirm dementia. A beautiful example has been given for this term by the Cleveland medical personnel, that if you don't know from a bunch of keys which key is supposed to open which lock, that is not dementia. But if someone sees the keys and doesn't know what they are and has forgotten what keys are meant for, that can be a case of dementia. That's the thin line of difference. So we came to the thing that is an umbrella term, which has various neurodegenerative conditions. But the common thing is there is a decline in the cognitive function and there is impairment in the functionality. Then severity may vary upon time. So age, though it is a primary risk factor, not a normal part of it. Dementia is not a normal part of aging. And in many of the cases, an early diagnosis can help manage the symptoms and slow down the progression, leading to an improvement in the quality of life. So coming to the signs and symptoms, how do we know? So the early stage, the recent events or information are forgotten. Questions or comments are repeated over a very short period of time. Keeping commonly used items at unusual spots, misplacing them, forgetting them. Some of them may not remember the year, the month, the season, the date. Then some people fight finding the right words to say. They are at a loss of words and they become silent all of a sudden. So all of these leads to a change in mood, in behavior, in certain interest. These are some of the early symptoms. Coming to the late symptoms, so complex task becomes much more challenging. The normal task, cooking, using a remote, it becomes much more challenging. Then rational thinking and behavior decreases further. Problem-solving ability is gone. The sleeping pattern changes. In some of the other cases, the biological clock itself changes. So there is anxiety, there is frustration, confusion, agitation, suspiciousness, depression, sadness. All of these are reported things. They need more help with activities of daily living. And in some of the cases, they even experience hallucinations. So what can be the cause? There are various, but medical. From a layman's point of view, it's a damage to the brain cells, which disrupts the communication between the cells, and this leads to a decline in the cognitive functions. So there is not one, but different types of dementia associated with specific brain changes or damages. So we have vascular dementia, that is from a reduced blood flow to the brain. We have the frontotemporal dementia, which the frontal and temporal lobes are included. Lewy body dementia by deposition of abnormal proteins, which affects the movement, cognition, and finally, even the visual perception. So accordingly, there are broadly three types of dementia. Primary, diseases and conditions in which dementia is the main illness. Secondary, it may be due to some other disease, and reversible, like dementia symptoms caused by other illness or causes. The first two, most of the times, they are not reversible. Starting with primary dementia. So the different types. The first and foremost, Alzheimer's disease. So what happens over here? There are two abnormal proteins, the beta amyloid proteins and the tau proteins, the tubulin associated unit. So this is a part of these microtubule associated proteins, which are found in the axons of the brains. They're responsible for the general network. But what happens is, due to certain characteristic features or what we saw the factors, these start getting twisted, tau proteins. And amyloid proteins, start getting forming plaques. So this leads to disruption in communication between the nerve cells in the brain. Starts with, how do we know that this thing has started? It's a short-term memory loss, an over-pervading confusion, certain changes in the behavior or personality, not finding words leading to trouble in talking, some memories which we find difficult to remember, issues with even walking. So 10% of the people above the age of 65 and above 50% of the people above the age of 85 have these diseases. And of course, family history definitely is an important factor. 60 to 80% of the worldwide population have dementia of Alzheimer's type. So this is how the brain looks. We can see the difference between a healthy brain and the Alzheimer's brain. You can see how it has shrunken. The ventricles, the hollow cavities, they become entangled with the tau proteins. The next among the primary dementia is the vascular, which counts for the second most, having 15 to 25% of the population. So caused by conditions like strokes, atherosclerosis that damage and block the blood vessels leading to the brain. So again, this may have memory problems, confusion, trouble in concentration, trouble in completion of task. So this decline may appear suddenly following a stroke or gradually if it is in a case of series of many strokes. So people who already have high blood pressure, diabetes, high cholesterol levels are already at a risk of this. Now, this is how our brain looks. During vascular dementia, there are the damaged blood cells, the damaged blood vessels, blood clots, series of small strokes. So these deprive the brain cells of oxygen and nutrients. Following this, there is abnormal buildup of protein clumps called as Lewy bodies. And so this type of dementia, we call it as the Lewy body dementia. So they cause damage to the nerve cells. They go on getting accumulated. So upon their accumulation, there is problems in the movement, in overall balance, changes in the sleep patterns. Of course, there is loss of memory, problems in planning, visual hallucinations. So it doesn't account for more, but at least 5 to 10% of the world populations are of this type. This is how the brain looks during Lewy body dementia. You can see the lobes, the midbrain. Shrinkage occurs in the temporal and the parietal lobes. Then we have the frontotemporal dementia. So this is, again, buildup of proteins, abnormal proteins, tau and TDP-43, that will attack the frontal and the temporal lobes. Where are these? Behind the forehead and the ears. And these directly affect our behavior, the language, motor functions. So upon attack of these abnormal proteins in the frontotemporal region, our social behavior is affected, personality is affected, the language skills are affected. Either we fail to speak or we fail to understand. We forget the meaning of common words. So it is a common case of early dementia between the ages of 45 to 64 and doesn't affect much, but at least 5 to 6% of the world population have shown frontotemporal dementia. So this is how it looks. TDP-43, that is your transactive response DNA binding, 43 kilodaltons or TAR DNA binding protein 43. And tau proteins, we have already seen the tubulate associated units. They attack the frontal and the temporal lobes. So there is a condition of mixed dementia where Alzheimer's and vascular, both symptoms have been found. And it is most common in people above 80 years of age. So this condition is a bit hard to diagnose, okay, because the obvious symptoms of each type may overlap. And in this case, the decline, the cognitive decline is much faster. Coming to the secondary dementia due to other conditions. So there we have seen dementia in case of Huntington's disease, which is a neurodegenerative inherited disorder affecting the brain cells, Parkinson's disease, loss of dopamine-producing neurons. The Creutzfeldt-Jacobs disease, it's again a neurodegenerative disorder caused by abnormal proteins called prions that accumulate in the brain, making it to resemble like a sponge. The brain resembles a sponge that leads to the other conditions. Wernicke-Korsakoff syndrome, that is caused by deficiency of vitamin B1. And most of the times it is associated with alcohol abuse, but there can be many other reasons like malnutrition or other medical conditions. A traumatic brain injury, so rare cases, but sometimes a very high blow to the head externally may cause some damage to the brain, leading to secondary dementia. The third type, that is reversible. This is also due to other deficiencies. We have normal pressure hydrocephalus, in which the cerebrospinal fluid builds up in the ventricles of the brain, and it causes accumulation, leading to infections. Deficiency of vitamins B1, B6, B12, vitamin E may also lead. Certain infections like syphilis, HIV, urinary tract infections, COVID also was found to be. Certain metabolic and endocrine conditions, Cushing's syndrome, Addison's disease, diabetic conditions, hypoglycemia, hyperglycemia. Some other side effects of medicines like sleeping pills, anti-anxiety drugs, antidepressants, the anti-seizures drugs, and certain other processes like your brain tumors and even the subdural hematomas, that is the bleeding. So what happens to the brain during dementia? So as we saw in the pictures, there is a shrinkage, reduced brain volume, loss of neurons. There are plaques and tangles of the beta amyloid proteins and the tau proteins. There is inflammation, there is oxidative stress further, which contribute to the neuronal damage, and they lead to the progression of cognitive imbalance and decline. Then at the neurotransmitter levels, there are changes like acetylcholine, serotonin, dopamine, disruption in the brain signaling, and thereby affecting the overall cognitive methods. So normally, a brain will have well-defined structures: the cerebral cortex, amygdala, cerebellum, hippocampus, and each of them have their specialized functions. The neurons will form complex networks, and that help them to communicate through these networks called synapses, enabling the process of information passing and transmission. So in this way, the brain will maintain a delicate balance of the neurotransmitters, other chemicals, and that will further ensure an optimal brain functioning, leading to cognitive performance. The blood-brain barrier will protect the brain from harmful substances, and the brain will always exhibit a plasticity, that is the ability to reorganize and adapt in response to experience, learning, injury. So this will promote a resilience in the cognitive functions. This is how it looks, our normal brain. Now during dementia, as we have seen, there is loss of neurons in the areas of memory, cognition, behavior. Lots of plaques and tangles are observed. There is inflammation, there is oxidative stress. Blood-brain barrier may become compromised, so there can be entry of unwanted substances, harmful substances. There is reduced brain volume. The cortex of the hippocampus regions are mainly affected, so reflecting the loss of neurons and synapses. So this is how our healthy brain looks, and this is how under dementia, specifically Alzheimer's condition, as it affects maximum, this is how the tangles look, this is how the plaques look, and how you can see the difference between a healthy neuron and a diseased neuron. So again, to sum up, what can be the different parameters differences between a normal brain and a dementia-affected brain? So first of all, there is shrinkage in the volume in dementia-affected brain. The neurons, they keep losing. The synaptic disconnection is happening. Whereas in case of a normal brain, there is a healthy, dense network of interconnected neurons, clearly showing the synapse. Amyloid plaques, they are either minimal or completely absent in case of the normal brain, whereas in dementia-affected brain, they go on accumulating. The neurofibrillary tangles, none or very few in case of the normal brain, but they go on accumulating in case of dementia-affected brain due to that hyperphosphorylation. There are balanced levels of neurotransmitters like acetylcholine in a normal brain, healthy brain, whereas when dementia starts affecting, the acetylcholine level goes on reducing, along with a reduction in levels of serotonin, dopamine, etc. So all these together will affect the cognitive functions. There is impaired memory, impaired reasoning, language, orientation, whatever we have seen earlier. Normal brain will always have a stable mood and normal emotional responses, whereas a dementia-affected brain will have mood swings, depression, a certain kind of apathy, and sometimes aggression and anxiety. So the inflammatory markers like cytokines, the glial activation, they are at the normal level in the normal brain, healthy brain. But in case of dementia-affected brain, there is more inflammation, there is activated microglia, there is less oxidative damage in the normal healthy brain, but in case of the dementia-affected brain, we have seen high levels of the reactive oxygen species. There is instances of lipid peroxidation, the malondialdehyde content. Synaptic connectivity is higher in healthy brain, but it reduces in the dementia-affected brain. Normal glucose uptake and metabolism is observed in the cerebral part of the normal brain, but in case of the dementia-affected brain, there is hypometabolism, whereas the regions are affected. Intact blood-brain barrier with a controlled permeability is always there in the healthy brain. But as we saw in dementia-affected, it is compromised and there is increased permeability. So upon taking an MRI or CT image, normal brain anatomy and volume will be found. But in case of a dementia-affected brain, the images will show cortical thinking, enlargement of the ventricles, and atrophy in the hippocampus areas. So mini-mental study examinations, cognitive test, they will show high scores for a normal brain and very low scores, depending upon the severity of the dementia. Followed by histopathology, we will see degeneration, plaques, tangles in case of dementia-affected brains. So how to know whether somebody has dementia or not? So there has to be a thorough medical study. There has to be a thorough medical study, thorough physical examination. So what could be the symptoms? Tests for assessing the memory, attention, language, other cognitive functions. MRI and CT scans to see the structural changes in the brain. Certain blood tests to find out whether there can be vitamin deficiencies or thyroid problems, which may also lead to cognitive symptoms. Some of the cases, there can be genetic testing to find genetic mutations associated with family history types of dementia. So when we undergo for a neurocognitive testing, so neurowritten and computerized tests are done to evaluate our ability of problem solving, learning, judgment, memory, planning, reasoning, language. And then this is followed by a psychiatric evaluation to find out the signs of depression, mood change, or any other mental issues. So coming to the risk factors, what can age, although it is not the only one, age is the most significant factor. And risk increases as we get older, not inevitable. Family history, definitely there has to be. Cardiovascular factors, high blood pressure, high cholesterol, obesity, diabetes, they may increase the risk of dementia. Certain lifestyle habits like smoking, inactive physical activities, poor diet, they can lead to it. And any traumatic brain injury or a repeated head trauma that can elevate the risk of developing dementia later. So coming to the conventional treatment method. So we have these classes. The cholinesterase inhibitors, N-methyl D-aspartate or the NMDA receptor antagonists. A combination of these two followed by amyloid beta targeting agents. And recently investigation still going on, tau protein targeting agents. Let's see them one by one. The cholinesterase inhibitors. So as we have seen, this dementia or specifically the Alzheimer's, it involves loss of cholinergic neurons in the forebrain. So this leads to reduced level of acetylcholine, which is a neurotransmitter essential for memory and learning. The two enzymes that break down this acetylcholine are this acetylcholinesterase and butyrylcholinesterase. So cholinesterase inhibitors act by inhibiting these two enzymes. So they increase the availability and duration of action of acetylcholine, especially at the hippocampus and cerebral cortex synaptic junctions where it is needed. So these are the drugs. We have donepezil, rivastigmine, galantamine, and below each name, I have mentioned the brand names and the companies that manufacture them. So these are the details. Highly selective for acetylcholinesterase, that is for donepezil. Rivastigmine, it inhibits both the acetyl as well as the butyrylcholinesterase. Galantamine, it's an acetylcholinesterase inhibitors plus an allosteric modulator of the nicotinic receptors. So these are some of the drugs of this first category. However, as we know, drugs affected with side effects are always there. There is bradycardia, hypotension, there is insomnia. These itself leads to dizziness, weight loss, muscle cramps, and they are contraindicated in cardiac abnormalities, severe asthma or other respiratory problems, peptic ulcers, or even urinary disruptions. Should not be given. Second, as we saw, the N-methyl D-aspartate or the NMDA receptor antagonist. It acts on the glutamate, that is the excitatory neurotransmitter in the brain. So overactivation of this NMDA receptors leads to influx of the calcium ions, which further leads to excitotoxicity, over and excessive oxidative stress, neuronal injury, apoptosis. So the drug used in this category is memantine. It is a NMDA receptor antagonist. It acts by binding to the open channel of the NMDA receptors, selectively blocks the excessive glutamate activity, and thereby protects the neurons from the glutamate-mediated excitotoxicity. So memantine, these are the brand names and the companies that manufacture them. Side effects, it has hypertension, dizziness, headache, confusion, constipation, and it should not be given to patients who already have severe renal impairment, a history of seizures, or if they're hypersensitivity to memantine. A combination of both donepezil and memantine is also used. So they work synergistically, enhancing memory and attention and preventing the neuronal damage. Then we have the amyloid beta targeting monoclonal antibodies. So as we have seen, accumulation of the beta amyloid plaques, which are a part of this abnormal cleavage of amyloid precursor protein. These get accumulated and disrupt synaptic function, cause inflammation, leads to loss and neuronal death, the synaptic loss and neuronal death. So certain monoclonal antibodies have developed like aducanumab, lecanemab, donanemab, which bind to the aggregated forms of these beta amyloids, and they cause immune-mediated clearance, prevention of further plaque formation, and reduction of the toxic oligomers, which are even much more damaging than the plaques. So we have these drugs, as we said, with their mechanisms. Aducanumab builds the beta amyloid plaques, binds to it, and stimulates phagocytosis. So lecanemab binds the earlier forms of beta amyloid aggregates, clears before the plaque formations. And we have donanemab, which targets specific forms of the beta amyloid plaques present in the matured ones. So these are the drugs which were the first to show slowing of clinical design, a decline in the features of Alzheimer's disease, but constantly they require MRI monitoring because there is amyloid-related imaging abnormalities, or ARIA, that has to be constantly monitored. Otherwise, these drugs are promising. So side effects, as we saw, there is amyloid-related imaging abnormalities, there is swelling in the brain, dizziness, headache, and it should not be given if there is already a history of intracerebral hemorrhage, bleeding disorders, or patients who are at a high risk for this ARI. So these drugs are still under investigation, tau protein targeting agents. They directly target the tau protein. So they will block the aggregation of the tau proteins, prevent the transneuronal spread of the tau proteins, and promote their clearance via immune mechanisms. So drugs still in clinical trials, we have semorinemab and zagotenemab. So these are the drugs and these are the names of the companies, Roche and Eli Lilly, which are still under the clinical trial phases. So there comes integrative medicine, why we should go for it. So it is essential in managing neurodegenerative conditions because it incorporates several treatment methods and mostly it combines the traditional practice and the modern science. It has an overall holistic approach. So it addresses not only the physical symptoms, but also the emotional and psychological aspects, as we have already seen. It starts with at a senior age, as an old age. So there are various emotional disturbances. There are various conditions leading to stress. There are various conditions leading to the psychological aspects. So we have to be careful while dealing. So if we have this integrative system, there is a wholesome, holistic approach. So when we combine phytotherapy, cognitive therapies, lifestyle interventions, integrative therapy enhances the efficacy of the treatment plans. And studies have shown that this type of synergy has already led to improved cognitive functions, a better quality of life, and it slows down the disease progression. So this collaborative nature, it will lead to a personalized treatment also. And individual patient needs can be catered over this. So under this integrative, let us see first of all the phytotherapy, that is treatment with the medicinal plants. So combining phytotherapy with cognitive therapies. So this has led to some transformation in the treatment plants. Some of the medicinal plants have been studied for the neuroprotective properties when given along with traditional cognitive therapies. And various studies have shown that plants have been showing promising results and they give supportive effects that facilitate cognitive preservation restoration. But how do we test them? Whether it is a medicinal plant, whether it is a chemical entity which is supposed to be tested for dementia. So how to go for them? So there are certain in vitro and in vivo models to test. So starting with the in vitro models, we need to perform cholinesterase inhibition assay to inhibit. It's a test to inhibit acetylcholinesterase and butyrylcholinesterase, as we saw in the mechanism, how it happens. So our drug should be able to inhibit them. Beta amyloid aggregation inhibition assay, again, to evaluate the anti-amyloidogenic potential. This assay has to be performed. Further, in the in vitro studies, we have the neuroprotection in cell lines. We have this SHSY5Y, PC12, HT22 cell lines in which it is studied, and we perform assays like MTT, XTT, the lactate dehydrogenase, and the DCFDA for the regeneration or for the generation of reactive oxygen species. Phosphorylation of the tau proteins, which directly leads to the anti-Alzheimer's property. So measuring the amount of hyperphosphorylated tau, we use methods like Western blotting, ELISA for this. And then we conduct the antioxidant activity via DPPH, ABTS, ORAC, and the Therapy activities. There are several activities to find out the effect of our medicinal plant extract or any synthetic drug on the oxidative stress levels. So these were the in vitro parameters or the models. Coming to the in vivo models. So in vivo models, the basic principle is we have to induce dementia-like conditions in the animal models, and we have to use certain chemicals for this. Under this, First of all, the commonly used one is scopolamine-induced amnesia. And it has been found that scopolamine induces a reversible memory impairment. How? By blocking the muscarinic receptors. And then, after inducing amnesia type of thing, we perform tests like the Morris water maze test, the Y maze test, the passive avoidance test to find out the effectiveness. Further, we have the beta amyloid intracerebroventricular model. It directly mimics the amyloid plaque formation and the neurotoxicity. Then we have aluminum chloride-induced neurotoxicity. It causes tauopathy and cognitive impairment follows. And then we evaluate the levels of acetylcholinesterase, malondialdehyde, superoxide dismutase level to find out the anti-dementia properties. Lipopolysaccharides or streptozotocin-induced neuroinflammation. This will also mimic the neuroinflammation-linked Alzheimer's progression. So here, after inducing, we perform tests like estimation of the TNF-alpha, the interleukin-6, and brain histology. Then we have the transgenic mouse models, which are already developed for certain studies, genetic models, containing the human beta amyloids and tau pathology. So these are mainly used for the long-term studies. So following these in vitro in vivo models, many medicinal plants have been studied. In this particular presentation, I'm showing some of the plants that have shown the best of the activities. So the first to show the maximum activity was Ginkgo biloba, made in hair tree synonyms belonging to the family Ginkgoaceae. It is also known as the living fossil because it is the only living plant available right now belonging to this family, Ginkgoaceae. All other plants have become extinct. So how it acts? It has been found that it enhances the cerebral blood flow. So when there is more blood flow, there is more oxygen and nutrient delivery to the brain. So cognitive function improves. So it contains the terpene trilactones, ginkgolides, and the bilobalides. They act as antioxidants. So the free radicals are scavenged. So further oxidative stress damage is prevented. They also act by modulating acetylcholine. They stop its breakdown, improving the memory and learning abilities. Along with that, Ginkgo biloba also has shown anti-inflammatory properties. So neuroinflammation is prevented. So further dementia progression and neuronal damage is stopped. And again, it has also shown protection against beta amyloid plaque formation. These were the mechanisms that has been studied for this plant, and it is the one which has shown the maximum activity. Followed by the humble turmeric, Curcuma longa, belonging to Zingiberaceae family, containing curcumin, the most potent anti-inflammatory agent till date. So this will suppress the inflammatory pathways. So the brain immune cells, the microglia, activity is enhanced, and that prevents excessive inflammation and further damage at the neuronal stage. Added to this, it also acts as a strong antioxidant, promotes neurogenesis, stimulates the growth of neurogenesis, and this also inhibits the formation of tau proteins and the beta amyloid plaques. Brahmi, Bacopa Plantagenesis family, very famous for memory and learning. So how does it do? It enhances the nerve impulse transmission in the brain. So the main active components that are the bacosides, triterpenoid saponins. They protect the brain cells from the damage caused by oxidative stress, having their antioxidant action. These also increase the cerebral blood flow, modulate the neurotransmitter levels of acetylcholine, and reduce amyloid deposition. Rosemary, that is Salvia rosmarinus of Lamiaceae family. It also enhances the memory, consciousness, the cognitive performance. It mainly contains esters, rosmarinic acid and carnosic acid that have antioxidant properties, mainly protecting the neurons from oxidative damage. They also have been found to enhance the cerebral circulation, inhibit the acetylcholinesterase activity, promote nerve growth factor. So this will support the growth of the neurons, their survival, and also it has shown a positive effect on the repair of damaged brain cells. Indian pennywort, Centrella asiatica, belonging to the Apiaceae family, is also locally in the rural areas of India. It is well known for improvising our cognitive function, memory. It also enhances the blood circulation to the brain and also has antioxidant activities. So the main active constituents are the acetylcholics and the madecassosides. They are mainly antioxidants. But along with that, they also promote the nerve growth factor, supporting the neuronal growth, enhance the neurotransmitter activity, reduce inflammation in the brain, so preventing further neuronal damage, thereby supporting cognitive functions. Then came this Chinese plant, toothed club moss or Cuperzia serrata, belonging to the Lycopodiaceae family. It's also already a recognized drug in the traditional Chinese medicine. So this also has been found to inhibit acetylcholinesterase, protects the neuron from the glutamate-induced excitotoxicity, enhances the neuroplasticity, exhibits antioxidant properties, and additionally, it supports the mitochondrial functions, thereby improving the cellular energy production. So it contains this huperzine. It's an alkaloid. Then comes Indian ginseng or ashwagandha, Vidania somnifera of the Solanaceae family. It has been known to reduce stress, reduce anxiety, to reduce the cortisol levels. So all these benefit the cognitive functions. The major active constituents vidanoids, they have neuroprotective actions, protecting brain cell from damage. They also have antioxidant property, promote nerve regeneration, plasticity of the synapses, enhance the neuronal connections, memory consolidations, cognitive activities. And these also have been found to reduce the amyloid beta plaques. Sage leaves, flowering tops, Salvia officinalis of the Lamiaceae family. Again, this also contains rosmarinic acid, so which has shown inhibition of acetylcholinesterase activity, improves mood and alertness, reduces inflammation, supports a healthy blood flow to the brain. So we have adequate oxygen, adequate nutrients. So these overall aids in our cognitive functions. So after seeing these medicinal plants, which were studied at the extract level or at the phytoconstituent level, the next level research led to nanoformulations, the targeted drug delivery. Why? Because the nano formulation showed certain advantages over the conventional dosages or even the extracts. And notable among these advantages were an enhanced blood-brain barrier penetration, leading to improved bioavailability of the drug and target delivery of the drug. So some of the nano formulations that were studied using these herbal drugs were liposomes, solid lipid nanoparticles, nanostructured lipid carriers, nanoemulsions, microemulsions, cubosomes. So how do they generally act? Now these herbal, when they are incorporated to the nanoparticles, they will enhance the blood-brain barrier capacity by exploiting the nano-cell structure and certain surface modifications that will allow them to bypass the blood-brain barrier more effectively and thereby facilitating delivery of the compounds directly on the brain tissues. Further, we add certain biocompatible polymers and surfactants or certain targeting ligands to the surface of these nanoparticles that will further enhance the stability, biocompatibility, and effectiveness for targeting. So we generally use polyethylene glycol. Then certain ligands, peptides, antibodies can be coupled to these nanoparticles, again to enable targeted binding. So certain techniques which get used to increase the blood-brain penetration, optimizing of the surface change, particle size, the surface modification methods, these are all done to enhance the blood-brain barrier penetration. So smaller than 200 nanometers, the size, they have demonstrated the fastest blood circulation and increased blood-brain barrier permeability. So as we have seen, the hydrophilic polymers like polyethylene glycol They alter the surface of the nanoparticles. So they gain stealth qualities, which decrease the opsonization, increase the duration of circulation within the body. Then, selective binding to receptors expressed on the blood-brain barrier is again possible by attachment of the targeted ligands to the surface of these herbal nanoparticles. So this further promotes the brain uptake. So bioactive substances like the herbal extracts can be protected from the enzymatic degradation when given the control release kinetics by enclosing them in nanoparticle carriers. And this further will reduce the systemic toxicity and maximize the therapeutic efficacy. These are examples of some of the phytoconstituents which were converted into nanoparticles, and they have shown enhancement of neuroproductivity, increased bioavailability, improved pharmacokinetic studies. They have also shown increased uptake, concentration in the brain, enhanced reverse memory and learning impairment, and improved stability and controlled release. So studied on carbon nanotubes, liposomes, polymeric nanoparticles, dendrimers, gold nanoparticles, and the potent drugs which have shown with curcumin, piperine from the black pepper, green tea, ginkgo, Bacopa which we have just now seen, red grapes, which contain resveratrol, Bidania somnifera, Silybum marianum, containing silymarin. So all these are converted into the suitable nanoparticles, and they have shown further advantages. So these are some other examples that have been studied. So curcuminoids have been developed into lipid-based nanoparticles, certain terpenoids and flavonoids into polymeric nanoparticles, epigallocatechin gallate into liposomes, bacosides into acetylene or solid lipid nanoparticles. Nanoemulsions have been made using vithanolides, nanocrystals using rosavine cytotroside. Ginsenosides from ginseng have been developed into polymeric micelles. Huperzine A, which we have seen just now, the alkaloid, has been developed into nanogels, silymarin into nanocapsules, and we have this nanosuspensions of rhinocarbaphyllin, which have been developed and have shown effect upon the cognitive functions. So these are the mechanism of action. Mostly what we have already seen. Either they will enable the beta-amyloid aggregation, okay, promotion of the synaptic plasticity, modulation of the neuroinflammation and antioxidant defense mechanisms, inhibition of acetylcholinesterase, reduction of the oxidative stress, suppression of inflammation. These were the basic mechanisms which we have seen that were shown by the solid lipid nanoparticles in a much better way. These nanoparticles showed as compared to the individual extracts. So as we are talking about the integrative therapy, certain foods which should be present in our diet to have a control over dementia, they have been studied. So accordingly, we have colorful fruits, vegetables. So carotenoids, which are responsible for the color of the fruits and vegetables. Carrots, squash, bell peppers, tomatoes, papaya, and the leafy greens, spinach and all. They have been found to be associated with better brain health and thereby a lower risk of dementia. Strong antioxidants are berries, blueberries, blackberries, raspberries. They contain flavonoids, which prevent the cell damage and stop the progression of brain damage from the free radicals. Certain amount of fish, particularly the sea fish, fatty fish, salmon, tuna, they have plenty of these omega-3 fatty acids that are associated with proper functioning of the brain and reduced risk of cognitive decline. Certain nuts, seeds, and legumes, we have them in general practice, the walnuts, soya beans, pumpkin seeds. They also contain antioxidants and omega-3 fatty acids, along with vitamin E, vitamin B, choline, magnesium, zinc. So these all have been proved to promote brain health and reduce age-related cognitive decline. certain whole grains like barley, quinoa, oats, brown rice, which are rich in fiber, the vitamin B, and certain other nutrients. They have been found to reduce inflammation in the brain, supporting memory and hence keeping dementia at a bay. So to conclude, integrative approaches merging with traditional medicine and the modern practices definitely provides a comprehensive framework for treatment. As we have seen, we have the allopathic medicines, the herbal medicines, and even the diet. Along with this, we also have certain lifestyle-related changes. We also have certain exercises which also support this. So further, when we address such conditions in a holistic manner, utilizing phytotherapy, lifestyle interventions, there has been significant improvement in the patient well-being and cognitive functions can also be achieved. So there is a need for continued exploration in this field. Further, we can get optimized treatment methods and better outcomes for dementia patients. So ongoing research and advantages definitely hold promise for involving and improving the quality of life for those affected by this condition. These are some of the references which I followed. Here's some of the sites. Thank you very much. So to sum up, I can say that it has to be a mix of everything. Even recent research is also showing that certain exercises, yoga, certain pranayam, certain asanas, they can also be done to improve the brain function, to improve the cognitive function. Though they have not shown a direct correlation with it, but the effects are observed. So there are certain exercises, there are certain lifestyle changes. A sedentary lifestyle leads to a damaged brain cells, the cognitive impairment. So they say that social life and all these, they will definitely help in having a better brain function. So thank
Right,
you.
sir. Thank you so much. Yeah. Yes, sir. Thank you so much, sir, Dr. Rakesh Barik, sir, for delivering such a thought-provoking and insightful session on integrative approaches in dementia, synergizing traditional medicine with modern science. Your comprehensive discussion beautifully highlighted the potential of blending age-old wisdom with contemporary scientific methodology to address one of the most pressing neurological challenges of our time. We truly appreciate the clarity, depth, and research-driven insights you brought to this topic. Your talk has inspired meaningful reflection and sparked new ideas for collaborative innovation in neurodegenerative research. Thank you once again for your valuable contribution to the 90th SPSR webinar. Now there are some questions from the participant side, sir, and I will
Yeah,
be asking you one by one.
sure, sure.
The first one is, right, sir. The first one is, how does integrative medicine redefine our approach to treating the different types of dementia?
How does integrative medicine help? Yeah, as we have seen that we need to integrate them because these are certain things, as we said, that any type of forgetfulness doesn't means dementia. So there has to be a proper
Right,
diagnosis first. And then whether it is at the early stage or at the late stage. So maybe a change in the diet, maybe a change in the lifestyle that can help. Maybe the patient does not need to have any proper medication also. And accordingly, if the person has already shown these and is at a later stage, so integrative therapy helps in all because this is a psychological condition as well. At this age,
right,
people do start feeling deprived, frustrated, and along with this, if they know this, that they are forgetting things and all. So that is why this integrative therapies are always used.
right, sir. Thank you so much, sir. The next one is, sir, what roles does early diagnosis play in enhancing the effectiveness of integrated interventions?
Yeah, early diagnosis mainly will lead to know the plasticity level of the brain. Like we have seen the neurogenesis, okay, the ability
Right,
to develop, the ability to repair, because as it gets older, that plasticity reduces. So early diagnosis will lead to this knowledge about the plasticity. So accordingly, treatment can be given. This is
Okay,
one
sir.
factor.
Thank you so much. Ji. The next one is, sir, how among the medicinal plants discussed, like Bacopa, Ashwagandha, Ginkgo, which one has shown the most consistent clinical efficacy and cognitive improvement?
Well, among these, I think Ginkgo is also
Okay,
available. Uh, I think Himalaya and many other companies also they sell this. And Ginkgo has shown that the
right,
most
sir.
consistent and most
Good
variety
effect.
of mechanisms it has shown.
Right, sir. The next one is, sir, are there any known interactions between conventional dementia drugs and phytotherapeutics?
Yes, yes, because this cannot be overruled. Interactions will be there as we are combining herbals with synthetic ones. Yes, again, it is Ginkgo, which has shown because Ginkgo, but not directly with the dementia drugs or like this. It has shown with certain other drugs which are taken. Like suppose patients are advised to take aspirin, and
Right.
Ginkgo itself has an antiplatelet activity. So aspirin is taken
Okay.
along with the other drugs for dementia, Alzheimer's. So this may lead to increase in bleeding. So
Right.
patients, those who are taking both, they are advised to
Synergistic
stop
effect
taking.
can be
Yes.
right.
So they are advised to stop taking Ginkgo. So
Okay.
certain cases. So this should be completely under strict medical supervision, even if
Right.
it is herbal.
Right, sir. Thank you so much, sir. The next last question is, sir, how can academia, industry, and clinicians collaborate to bridge traditional knowledge with modern scientific validation in dementia treatment?
It's a great question. Right question. Yes, we need to collaborate. Academia conducts research, finding the traditional plants, the traditional methods. Industry needs to collaborate with us to tell us what sort of formulations can be produced so that they can be easily available. Clinicians need to conduct the tests of it. Then only we develop because we see, as we have seen, that there are so many medicinal plants that have been studied. A few of them have shown promising. Among them, one has shown the most promising. So most of the times, these end up in very good quality publications. Of course, it is required. What we are working, the entire world should know. But after that, what? So suppose a drug has shown, then let the industrialists come, let the clinicians come, let there be a collaboration. Then only we develop drugs for this. So that can
Right,
be
sir.
done.
That's true. So thank you so much, Dr. Rakesh Barik, for answering all the questions so thoughtfully and with such depth. Your insightful responses have added great value to today's discussion and have helped us better understand the promising intersection of traditional medicine and modern science in dementia care. We sincerely appreciate the clarity with which you addressed each query and the real world relevance you brought to the session. Thank you once again for your time, expertise, and outstanding contribution to the 90th SPSR webinar. Thank you so much, sir.
The
So here
honor
we
and
come to the
pleasure is both mine. Thank you once
thank you
again,
so much.
SPSR.
Thanks, sir. So here we come to the conclusion of this session, sir. So as we conclude the 90th SPSR webinar, we extend our sincere thanks to Dr. Rakesh Barik for his enlightening and forward-thinking presentation on integrative approaches in dementia, synergizing traditional medicine with modern science. Today's session offered a rich exploration of how ancient knowledge and modern scientific advancement can converge to address the complex challenge of dementia. Dr. Barik's insights into the medicinal plants, nano formulations, lifestyle modifications, and synergistic treatment models have broadened our understanding of integrative approaches and their potential in enhancing cognitive health. This session emphasized not only the scientific validation of traditional systems, but also the importance of collaboration across disciplines to develop safer, more effective, and holistic solutions for neurodegenerative disorders. On behalf of the SPSR, we thank Dr. Barik for his impactful contribution and all our participants for their enthusiastic engagement. We look forward to welcoming you to our future webinars as we continue to promote interdisciplinary dialogue and innovation in pharmaceutical sciences. We are deeply thankful to Dr. Shashi Alok, the National President of SPSR, for honoring us with his presence. We recognize and appreciate your commitment and guidance, and we offer our profound thanks for your significant input. We would also like to express our appreciation to our convener, Mrs. Monika Sabharwal, for her pivotal role in organizing this event. We extend our gratitude to all the SPSR team members for their collaborative efforts, which have broadened our understanding and fostered cooperative learning. Your collective contributions have made this webinar a success, and we look forward to continued collaboration in advancing pharmaceutical sciences and research. We look forward to your participation in future SPSR webinars as we continue to explore groundbreaking topics and foster knowledge sharing in pharmaceutical sciences. Thank you once again, and we wish you all the success in your endeavors. Have a wonderful day ahead. Thank you so much. Thank you, sir, from Team SPSR.
Thank you very much.